Good morning, everyone. Thank you for joining us. I'm Kirsten Shirk. I am the Senior Advisor for Media Strategies at Ipas, and I'd like to thank you for joining us in a somewhat of an experiment in a group briefing, bringing together people from around the world. This has been a really interesting technology to use, but as new technologies go, it has some challenges. Our plan is to have a discussion today about the impact on the Helms Amendment on abortion access for women overseas. And our colleagues in Kenya and Malawi are having some challenges getting connected. So I'm going to hand it over to my colleague Barbara Crane, who will start talking while I keep working on the connections. So, Barbara, take it away.
All right. Well, thank you all for being with us. As I think many of you know, Ipas is an international non-governmental organization that works to reduce deaths and injuries from unsafe abortion and to advance women's sexual and reproductive rights. We've been working for a long time on the Helms Amendment issues, and today we want to share some of our experience and concerns around this issue with you. The Helms Amendment is a law that's been around for more than 4 decades that simply and basically says the U.S. government will not pay for the performance of abortion as a method of family planning. But the implementation of the Helms Amendment has gone much farther than that to prevent U.S. government funds from being used to meet women's needs and provide abortions, even in cases of rape or incest or danger to the woman's life. It has also had a far-reaching effect through censoring of all publications, websites, meetings, and other training materials, anything that the U.S. government is funding with USAID funds. Why does this matter? It matters because the U.S. is a major donor overseas for family planning and reproductive health and other health and development and women's empowerment programs. The U.S. supports family planning in more than 40 countries. And these services reach millions of women. At the same time, unsafe abortion remains as a major killer of women in countries that are receiving U.S. assistance. And rape is everywhere in our society, in these societies, and we've become even more aware in recent years of the situation of rape in conflict-affected countries like Syria and the Democratic Republic of Congo, where it is a weapon of war. The leadership of the U.S. government is completely missing at this point on these issues. We know that the Helms Amendment can only be removed through an act of Congress, but we also know that the Obama administration could legally step in and direct that U.S. funds could be used in these cases and could lift the heavy-handed censorship. Today we're going to be, we hope, connecting shortly with colleagues from 2 countries, Kenya and Malawi, where key stakeholders and leaders in those countries, in the government as well as in civil society, have been working to evolve national policies to ensure that more women are served with safe abortion. And in Kenya, actually, since the Constitution was adopted in 2010, there's a wider range of indications, including health indications for women to receive safe abortion. At the same time, in Malawi, there's been a process underway to reform the national law in Malawi. These are also 2 countries where the U.S. government is a major family planning and health and development overall. And these are therefore 2 countries where we really see the collision between U.S. policies and the realities for women's lives in those 2 countries. So today we're hoping to be joined, and in the meantime, I think we could definitely take some questions from all of you or comments about this policy. Our first speaker is meant to be Monica Oguttu, who's a nurse midwife who's been practicing for many years in Kenya, who's also a leading reproductive health advocate and also a executive director of a major NGO called Kisumu Medical Education Trust, based in Kisumu in western Kenya, where the needs of women are greatest. And working through her organization in more than half of the counties in Kenya around access to family planning, HIV prevention, sexual reproductive health information for adolescents, and safe abortion. Interestingly, she also has funding from USAID, and she will be able to speak to the challenges of an NGO trying to implement programs under the limitations of the Helms Amendment. She is also a recipient of the Margaret Sanger Award from Planned Parenthood Federation of America in 2004 in recognition of her leadership. So we do know she's there and trying to connect with us right now. So we hope she will be joining us very shortly. Our other speaker is a practicing physician from Malawi, Dr. Chizali Mahango. We know that he was on his way from his clinic to be with us. He is also a professor of OBGYN at the College of Medicine at the University of Malawi. Previously headed the reproductive health unit in the Ministry of Health, worked very closely with USAID on the implementation of family planning in Malawi, and has had a very distinguished career not only in Malawi but at the regional level in Africa. So he has a very broad view of the problems both in Malawi and in his own country and in the region. So we're very appreciative that we will have these two people with us, we hope, shortly. And I'm delighted to see that Monica Oguttu has appeared on the screen.
Thank you, Barbara, finally.
Yes, so Monica, if I may just bring you up to date, I've just made an introduction about what the Helms Amendment is, why it's important, because the U.S. is such a major donor to reproductive health, and the fact that the Obama administration could show leadership and change this policy. I've also provided an introduction for you and Dr. Mahango. Kirsten is working to bring him into our session this morning. But I would like to turn it over to you to make some comments from your perspective about the Helms Amendment and how it impacts women in Kenya.
Thank you, Barbara. Probably just to introduce where I started with my work as a midwife in charge of the OBS-GYN department in Kenya, in National Hospital, Kenyatta National Hospital. As the in charge of the department for almost over 10 years, I witnessed women die from botched abortion. And sometimes it's so sad as a midwife. The worst part is doing last offices. You know, they come today, tomorrow you do last offices, call the morgue, they carry a body and take to the mortuary. So after training, in 1996, I opted out to go to the community and started a local NGO with a few colleagues from the teaching hospital to go and save women beyond the teaching hospital. So my organization, KIMET, has been there since August 1996. And what I've been doing is to train my fellow midwives to save the countless women who are dying out here. I do a lot of training on post-abortion care and safe abortion within the law. And I also advocate with my county governments. I tend to be the voice of the voiceless women that we pack every day in our training hospitals. So basically, what we witness here is something that probably not many would want to share, but sometimes you have to share the experience, especially where the laws, we expect laws that will help us to save women. And sometimes we get the laws like the amendment, the Helms Amendment, which to us is really a harmful thing because it actually creates more barriers to access to safe services. So we have really witnessed a lot of challenges as midwives, as the frontline soldiers in the communities, where the access to services is not there, and the laws, the amendments like Helms Amendment has contributed to the challenges. So basically, maybe after if I'm asked more clarification based on the time I have, I can also share experience we have in the entire country.
Thank you, Monica. I could ask a question myself, but let me see if there is anyone in our audience yet. Kirsten, are you able to see if there's any questions coming from people who are listening?
So if you have a question, I think a number of you have already found this format. You can ask questions in your screen, and we will take them as they come, or I think Barbara will moderate a little bit when we want to sort of shape the conversation. But go ahead and feel free to type in any questions there. I think you can start a conversation with Barbara, and we'll just pick them out as they come along.
All right.
Okay.
So, do I see a question?
That's actually it's a question.
Oh, that's a technical question,
right?
Okay. Okay. Well, maybe I could add something to what Monica said of the situation in Kenya that I'm aware of. There has been, since the Constitution, an effort by the ministry to put in place standards and guidelines that would help the providers in both the public health system and also in private clinics to know how to interpret the indications that were allowed in the Constitution and to actually provide safe abortion in cases of danger to the woman's health or life. And we had a situation where the ministry released the guidelines in the fall of 2012. It took a little time after the Constitution, but they were in place. And then a little over a year later, the ministry began to be under some pressure and withdrew the guidelines and said they would need to be revised, and actually called a series of meetings involving the reproductive health organizations who would bring the most knowledge and evidence to the discussion of these guidelines. And we actually have in our hands a message that USAID sent to USAID recipients to say, do not participate in this discussion in your own country about the guidelines that affect the women of your own country, because these grantees of USAID would be potentially violating the Helms Amendment. So this was a particular example of how the interpretation of this law in the field to overreaching and interference and intrusion, about how to implement the Constitution. So it is this kind of situation that we would like to see the Obama administration change. There's also the impact on service delivery, and so many USAID-supported family planning providers have not been given the tools and information they need to support safe abortion. And that task has fallen to people like Monica to help fill the gap provided by USAID support. And so, Monica, I've said some of the things that I'm aware of about the situation in Kenya.
Sure.
I wonder if you would like to add some additional comments.
Thank you, Barbara, again. I think the genesis of our standards and guidelines was really encouraging, especially after the promulgation of the Constitution in 2010, October. We were all excited because at least our new Constitution is friendly, and we knew that we would get the standards and guidelines to help us implement the Constitution. But after the 1 year, and it was approved, and we started implementing, it has been withdrawn, and right now with a better Constitution, we are not able to implement. And as I'm based in the rural, because I'm really in Western Kenya, near Lake Victoria, and this is a region where many women area with very high maternal mortality due to unsafe abortion. So we knew with our beautiful Constitution we'll be able to implement and save many women, but it has not been the case. And from what we hear is that there is a lot of support from outside not to have this implemented. And for us, especially when you are a local NGO and you receive USAID funding, you cannot talk about abortion. Finished. And in the areas where I work, you'll get only one clinic with a midwife, and there's no way you can separate the services, because when this woman needs services, this is the only clinic that she would go to. So what we have been encouraging as local NGOs is to have a one-stop shop. But when you are receiving, which is a reality in Kenya, when you are funded by USAID, you don't talk about abortion. And Barbara, you know that the big fives that kill our women in Kenya, there's no way you can talk about postpartum hemorrhage, sepsis, obstructed labor, or hypertensive diseases in pregnancy without talking about abortion. So we have been really trying to ensure that these clinics are supported by other partners so that they can be able to offer holistic services to women, because it's the same woman who will come for family planning services that might come again with an intended pregnancy. Mark you, this is an area where even rape cases are not uncommon, and it's blocked. It's a barrier, whether it's rape, whether it's incest, you don't talk about it. So that is what we are saying, that if the Obama administration could authorize that these services offer a one-stop shop, because we need prevention to prevent that unintended pregnancy. But when there's the unwanted pregnancy, what does a provider do? Because you are not supposed to talk about abortion. And that is how we are getting now many women coming to us with all kinds of complications.
Yeah, so the U.S. government would say, you can do what you want to with other resources and other funds, you just can't use USAID funds for this purpose. But what you're describing to us is the reality when you get down to the ground, that this separation is very hard to achieve. And if it is achieved, it's achieved in a way that's detrimental to women, because they come into a provider and they need to be sent somewhere else for the services that they need. There was a question from our audience about whether you have actually treated someone. So this would be in the last few years since the Constitution was adopted. Have you treated someone who was not able to get a safe and legal abortion, who came in for with an incomplete abortion or a septic abortion, because they could not find safe services. Have you seen that specifically?
Thousands of them. I train midwives, and every time we are training, we receive very many complications. Recently, we were training in a county called Kisumu, and a young lady, a university student, came to us with a pipe. It was like a catheter, and this pipe had stayed there from Friday up to Monday when we were conducting the training, and she was very septic, very, very septic. The saddest part of the issue is that it becomes so expensive to treat now these complications. So we receive many, and we have been collecting a lot of case studies, which we are now sharing with our county government, because, you know, if only these women could be giving their stories, I'm sure the world would be listening, but most of them don't live to tell their stories. So we receive quite a number of complications because I am a trainer and I'm a service provider. And probably we can also collect some of those case studies and share with you if you allow us, because there are thousands of them.
Thank you so much for that. You just raised a point that I think is worth underlining about the cost of treating women who have complications and saving their lives, the cost to health systems, which is can be enormous. And we know that other donors are very committed to actually supporting safe abortion services, because they know not only is it a matter of women's human rights and health needs, but it's also a consideration for the health system, for the cost. And what that means is resources are directed to that when they don't need to be, and diverted from other important possible maternal health or other kinds of treatments that need to be given to women by the same small staff of providers in, let's say, a small district hospital. So the cost aspect of this is also an important consideration.
I'd just like to remind people that you're free to ask questions in the chat box to your right, and please keep them coming.
Do we have some additional questions?
We don't at this point, but I was going to encourage people to keep asking.
Right, and have we gotten any word from Dr. Mahango yet?
Yes, Dr. Mahango is having technical issues. The Wi-Fi network that he's trying to join is down. So
he's in Malawi.
He's in Malawi.
I think he's in one of the hotels,
yes.
But maybe the hotel system is not working.
Yes, this is one of. We're excited to have Dr. Mahango join us from Malawi, but one of the challenges of having, you know, as Monica knows from earlier this week, the Malawi broadband network is a little bit of a challenge.
Sure.
There's a question for you about your analysis of why the Helms Amendment has been so narrowly interpreted in the field.
Because there's been no guidance about how to interpret it or apply it, and also because the law was turned into a very specific set of limitations in the contract provisions for every USAID grantee and contractor. And so, not to get too deep into the policy weeds, but one can trace how the amendment has actually been formalized in USAID requirements for all grantees and see how narrowly it's been interpreted in that way. But it's also an area that is so confusing and so lacking in guidance that the inclination of USAID staff in the field, of grantees, contractors, recipients, small NGOs, is to say, better just not to get involved at all. People are very intimidated and concerned about their U.S. government funding, and so it's a lot easier for them to not try the boundaries. And that's my impression. Maybe Monica has some additional comments about that. The tendency, whether it's a government health official where the USAID is a donor or an NGO that's receiving funds, there's not a lot of impetus there to push the limit of what would be legally possible. Monica, would you like to comment?
Yeah, probably I'll comment on the issue that the USAID funding comes with a lot of restrictions, and where we are right now in the rural communities, those restrictions actually create more barriers, and that's why it's very difficult for us to offer services the way we would like to do, because there are some partners who are receiving USAID funding, and they would not like to partner with us even when we are engaging our county governments to talk about the high maternal mortality rates due to unsafe abortion. They would like to keep quiet about it so that they continue getting the funding, because they are scared they might be defunded. And you know, when you witness this death, sometimes you say funding or no funding, we'll have to talk about these issues. And that's why for us at KIMET, we have continued to talk about the issues. And the government currently, the Kenyan government, with the county approach, they are seeing the reality when it comes to maternal mortality, because the laws should be laws that reduce maternal mortality, and even policies should be good policies when they reduce maternal mortality. But when we look at some of the policies for us in Kenya, it's increasing our maternal mortality. 5 years ago, our maternal mortality ratio was 590 per 100,000 live births. After the global gag rule, our maternal mortality went higher. And right now, we are actually working on strategies to work with the county government, county by county, to see what strategies each county can have to reduce maternal mortality, because it's just too sad. There's no community that can develop with the high maternal mortality. So basically, that is what we witness.
Thank you, and we could come back to touch on the global gag rule and explain to our listeners at some point how the two policies are different, in fact, but both have these very harmful effects. I also wanted to comment and ask you for your comments about the area of post-abortion care. So USAID will tell other donors in the world, and they do deserve very good credit for supporting training in many countries around the treatment of emergency complications. But one of the effects of the Helms Amendment has been that USAID can support the training in post-abortion care, but they cannot support the core technology of manual vacuum aspiration. And MVA instruments are the basic instruments used in low-resource settings and all across Africa to provide post-abortion care and save women's lives. But USAID, because of the way Helms has been interpreted, cannot provide this basic technology. And I think, again, I'm giving you my impression, but Monica, please comment, that often leaves the local actors, the local service providers and ministries scrambling to find the resources to get hold of the technology that they need in order to provide even emergency treatment of unsafe abortion complications.
Sure, that is true, because I've also, thank you, Barbara, I've witnessed quite a number of partners, like we had the Prime project in Kenya, which I helped a lot in training of the midwives, but USAID funding would be used only for training, but not for equipment. So we had thousands of midwives who would be knowledgeable and skilled, but are not providing services, because when they go back, the government has no means or resources to avail the tools for them to offer the services. So what we have been encouraging is that we need a complete package. It has to be training, it has to be equipping, and then we offer support. The support, the systems in place, it has to be complete. But from my experience in the country, because I've developed quite a number of programs for midwives, quite a number of USAID funded projects would only offer funds for training. And that results into so many dormant midwives out there who are not offering services. And we believe that when you train a provider, it's like going to the farm. When you are going to your farm in Africa, you must carry a hoe. So you cannot go and till the farm without anything. So that's what we are trying to tell our leaders and our donors, our supporters. Train them and equip them. But you can't give one hand an authority to train and one hand no equipment. It's a waste of resources.
Very, very clearly expressed, and I know, because from my previous visits to Kenya, and I previously worked with USAID, that there's been a lot of support around logistics and procurement for contraceptives, which has been very, very important. But the organizations that USAID supports to provide that kind of logistics support on contraceptives are precluded from working with the government on how to forecast and plan for their needs for MVA technology. So that's an example of how this just out in so many different ways in program implementation. About the impact election results and how we think that might impact the future of review of this policy by the U.S. government. I want to hold that question for a moment. We'll see if there's some other questions. I'd also like to note, Monica, that you have done a lot just in Kenya. You've been training in South Sudan. I think you've worked in Nigeria. You've worked in Malawi, maybe Uganda. You've seen the similar issues in other countries. And I wondered if you just would like to expand on that for a moment to help people realize how pervasive the need is and how, again, the U.S. policy plays out in ways that are very harmful to women.
Yeah, the scenario is the same all over, Barbara, because Africa is a small village, and a few of us who have been going around in other countries. Personally, I've trained in South Sudan. In 2 weeks' time, I'm going to Eritrea. I'm leaving Kenya on 14th, going to Eritrea to help train the midwives. I've just come from Malawi, and it's the same. It's the same everywhere. In fact, one time when I was in Tanzania, a midwife told me that, Monica, this is a lot of waste of resources when we can train and we don't offer equipment. At the same time, training in post-abortion care only does not change our situation, because we have to look at abortion as, beyond the post-abortion care. We have to look at abortion from the prevention, and we need to do a lot of work on preventing the unintended pregnancy. But when now it happens, and a woman or a young girl comes to the clinic with the unwanted pregnancy, we need to offer services, safe abortion services. That is the only way we reduce the numbers that we are seeing in post-abortion care. And as one of our leaders in Africa said, post-abortion care is like mopping the floor of a leaking tap. Because this leaking tap in Africa are the many thousands of women we are seeing in our gynae ward for treatment of complicated complications of abortion. So if we can only go beyond the gynae room and offer the safe services, then we will reduce the number of complications we are seeing. So the situation is the same all over. I've been training in quite a number of our countries in Africa, and it's the same. You train, USAID funding is for post-abortion care, which I've told you is like mopping the floor, and you'll keep on getting this leakage coming to you, and it is really something that is worrying us. So that is why some of us will keep talking about this very sensitive and stigmatized issue, because we witness the cases every day in the entire Africa. And some of them are due to rape. Like in Kenya, during the post-election violence, we had so many women who were raped and ended up with unwanted pregnancy. Barbara, can you imagine carrying a pregnancy that you don't know the father? You have been gang raped with even more than 4 people. And sometimes it's very difficult for even this woman to carry this pregnancy. And that's why some of them do whatever it takes. They don't care even when they die. I remember during one of the trainings, I asked a woman why she used a crude method to procure abortion. And she looked at me straight and asked me, Monica, where were you? In fact, they'll call you Daktari, doctor, it's a Swahili word. Daktari, where were you when I was looking for help? I did this because nobody actually listened to my problems. So I think we need to be. I've gone off.
No, you're still
maybe
there.
Dr. Mahango needs to mute his mic.
I was going to say, I first just want to acknowledge that we.
My sincere apologies.
Dr. Mahango with us now.
Dr. Mahango, you can mute your computer for just a minute while Monica is talking, and then we'll throw it over to you.
Thank you.
But we're so pleased you could join us. Okay, Monica, continue,
Okay.
I think.
Am I there? Yeah,
You
so
are.
most of these women, by the time we meet them in our gynae wards with complications, they are so disappointed that now is when we are ready to do the mopping of the floor and asking them why they had to procure that abortion that way, why they want people to help them before they reach us. So I think we need to design programs, and we need to have laws that can help us save many women who are reaching us with complications. And some of them don't survive. And as I started by saying, it's the most depressing moment for us health providers. As a midwife, I just said enough is enough. It's like working in the Ebola region. If only unsafe abortion was like Ebola, I'm sure there'll be response all over. But unsafe abortion cases are dying silently, and the world is just watching. I think we need to do something, and we just need to create awareness the way we have done it in Africa with Ebola.
Thank you, Monica.
Thank you.
We are so pleased that Dr. Mahango is now with us. And just to catch him up, we've had a wide-ranging conversation about the far-reaching impact of the Helms Amendment, both in terms of how services are provided and made available that are legal in certain countries, and also the effects of censorship and limitations on discussion about abortion by USAID-funded organizations. Malawi, I explained to our audience, Malawi and Kenya have both been evolving their policies on abortion, and we know that Malawi's is at an earlier stage than Kenya in some ways, because Kenya has a constitution that clearly establishes safe abortion for certain indications. Malawi is working on its law. But I'm sure you are looking to the day when there will be a better law in place in Malawi, and yet here is the U.S. government as a major donor to Malawi and not in a position to support addressing the needs of women in Malawi. So, Dr. Mahango, I'd like to give you a few minutes to comment on how you see the situation in your own country, and what are your concerns about the impact of Helms both in Malawi and in Africa more generally? Did we lose him?
No, we might have lost him. That was so close. Let me try one more time. Okay.
Yeah.
Why don't you, do you want to talk about
I can tell you a little bit about Malawi from Ipas's experience working there. Quite some years ago, about 7 years ago, we connected with Dr. Mahango and other people in the ministry who were concerned about the problems of unsafe abortion in Malawi and said that they needed to have some assessment of what was the extent of the problem. So we worked in two ways. We worked with the World Health Organization to do a strategic assessment in Malawi, and also together with the Guttmacher Institute and other local unsafe in Malawi and its impact on women. And Dr. Investigator in that study. In 2010, there was to release the results of the study and discuss implications for Malawi and the way forward to it going to be leaders in government and civil society for a national discussion about the issue. And he was informed of SAID funding limitations. He would not be allowed to speak to the results of this study in the national meeting. And that was very unfortunate for him at the time, and for the feeling of optimism in Malawi that this problem could be tackled without the oversight and interference of the U.S. government as a donor. Since then, there has been a society to change the law, and the government is undertaking a review of the law. But here's just another U.S. government ag on progress, and if Malawi completes the process of changing the law, they will have to contend with dealing with the limitations of the U.S. support for family planning and health in Malawi under the limitations of the Helms Amendment. So it's a major issue in Malawi as it is in Kenya, and I so regret that we don't have Dr. Mahango to comment himself. We are really near the end of the time we had allotted, so I regret that I don't think we're going to get him back. Could we see if there's some additional questions? Kirsten, are there some questions?
There is a question that came out, actually, if you wouldn't mind addressing. Monica, the question, the person was asking a question about a challenge. Oh, we've got Dr. Mahango back. Go hold off if we can get Dr. Mahango. Are you there? Do you hear us?
Hello?
Oh, I think we're not quite hearing it. Well, while he gets connected, Monica, I wonder if you could address the issue of sexual violence among the populations you serve in Kenya.
And Kirsten, can we run over 5 minutes?
I hope, yes. I understand that we said that we would end at 11, but if people can stay on, we'll talk for a little bit longer since we're a little bit late getting started. So, Monica.
Yeah, sexual violence, Christine, thank you. Sexual violence is really rampant. It's high, like any other countries all over the world, especially in the region. It's high, and that's why we are having gender-based recovery centers. So we have quite a number of gender-based recovery centers, but safe abortion is not part of the services. So most of the times when these women end up with unwanted pregnancies, it's actually a nightmare. So it's I would just say that it's common, and we need just to integrate these services so that we are also able to tell them where to get safe services than leaving the centers and going back to the quacks. Yeah.
Thank you.
Dr. Mahango, can you hear us, or can you Are you off mute? Can you speak? I think we're still not hearing you. So I'll ask another question of Monica if I can. Monica, if you had a message for President, there's a question here, if you could transmit a message to President Obama, what would it be? Monica, did you hear?
Hello, come again. You are going? Your voice is going.
Oh, I'm sorry. There's a question here. If you could transmit a message to President Obama, what would it be?
My message would be on behalf of the many women out here who are actually dying from abortion. I would really ask or plead on their behalf that let's have laws that will help us save their lives, because so many of them are dying silently. So I would plead to the president, who actually comes from this region where I'm working in Kisumu. This is where his roots are. We need laws and we need support to have integrated services that will help us reduce the high maternal mortalities. That's the only way we'll have this region developed. Otherwise, with the high maternal mortality, we are not going to develop at all. We are losing women every day.
Monica, thank you for that powerful statement and for being with us today. Maybe we will be able to organize another such event with Dr. Mahango to benefit from his views. The question was asked about the impact of the election, and I want to be very, very clear that the politics of the United States around these issues and around the Obama administration are not going to impact at all on our commitment to work with the Obama administration to see a change, to see them implement what is legally possible and morally imperative. So stay with us in this process, all of you who are listening, those of you who are advocates, and we hope that those of you who write for the media will continue to help build awareness of what this policy means to women around the world. And I think we've heard very graphically today what it means for women in Kenya and in Africa. And Monica, we appreciate again your eloquence in this session we've had today. Thank you so much. And I think with that, we will say goodbye, and we will be in touch. Thank you again.
Thank you, everyone, for joining us today. There will be a video online later this afternoon on our at least on our YouTube channel, and later on our homepage. So I hope if you know people who wanted to be here, that you can pass the link along and tell them they can see it in reverse. So thanks, everyone. Thanks for joining us in this experiment. Have a great day.
Thank you.